Absolutely. Thank you very much, Debbie. I think this is a very, very exciting time and moment for me and for each one of us. Today, we will be looking at some of the very innovative things that we are looking at within the NTD world. Because as you all know, within the NTDs, we have this very ambitious goal of being able to eliminate these diseases, and where it is not possible, then we would like to, as much as possible, make sure that we achieve control. Now, as a country and as a national program, we have been thinking about this over the last many years. And 2 years ago, we started the process of being able to develop an innovative way of being able to, achieve this kind of this goal. Now, we have been able to make some strides, which we will be talking to you about within the next 1 hour, sharing with you. And generally, we will pick out a few issues that we will be able to share. Now, the issues that we have picked out, which will be able to showcase how we can build sustainable public health capacity within national NTD programs, because of time, are just about 4. So the first one will be mainly around a strategy that we have developed, which is called the breaking transmission strategy, that aims to achieve elimination of the main 4 PC entities in the country. And here we will be showcasing a comprehensive approach to implementation, which we will be told about just shortly. And we will be actually looking at, after that, we'll be looking at how it is possible to build broad-based partnerships, because we are looking at being able to work with very many other players within the sector and beyond, the health sector and beyond, so that we can achieve this goal. And we have picked out the example of the field epidemiology and laboratory training program in Kenya, and we will be told a little bit about this partnership shortly. We will also be looking at innovation in its form, because currently when you look at soil-transmitted helminthiasis and schistosomiasis, we generally carry out most of our surveys in a school-based kind of setup. But the breaking transmission envisages implementation within the community setup. And so together with the Children Without Worms, we are designing and implementing, testing a community-based survey, which we will be told about shortly. And then finally, we are looking at the regional approach, because this is something that is going to work best if we can have several countries, especially across Africa, being able to implement this particular approach. And so we'll be told about how AFENET is also coming in to ensure that we have this regional approach. So I just want to recognize the contribution that has been made by Children Investment Fund Foundation in developing the breaking transmission strategy for Kenya, which is actually a groundbreaking strategy that is going to change the whole ballgame when we talk about outcomes in terms of elimination and control of the PC entities. So we have 4 speakers today, and the first one is actually Dr. Stephen Mwatha. Stephen Mwatha is, he works within the Ministry of Health in the Republic of Kenya, and he will be telling us about the breaking transmission strategy. We will have about 48 minutes of presentations, and then after that, we will be able to take some of your concerns and some of your questions. Please feel free to put them into the chat box, so that my colleague Cara can be able to pick them out, and then we will be able to address them at the end of the presentations. So without any further ado, I'd like to bring in Dr. Stephen Mwatha, so that he can tell us a little bit about the Kenya National NTD Program, breaking transmission strategy, and your time, Dr. Mwatha, starts now. Thank you. Over to you.
Thank you so much, Dr. Sultani, for that introduction. So good afternoon and good morning to everyone. So I'll take you through the breaking transmission strategy, and I'll start with giving a small background on where we started. And breaking transmission strategies is part of it's a commitment of the Kenyan government in regards to achieving the global target of elimination and prevention of chemotherapy NTDs. And that entails the soil-transmitted helminths, the schistosomiasis, the lymphatic filariasis, and trachoma. And then this also is in line with what the global strategy is in terms of elimination. And in our strategy, we have a lot of collaboration, both at partners, at national levels, at county level, and as community level. And with this coordination, we also have interventions. So working with partners who work with WASH intervention, which includes the Ministry of Water and Irrigation and Ministry of Environment and Natural Resources. Next slide, please. So, and what informed this decision, it was based on studies that we did during the school-based deworming, where we tried to look and evaluate ourselves after giving school-based deworming for 5 years, what was the impact? And we did the pre and post analysis where we looked before the MDA and after the MDA, what were the results? And the interesting part from the charts on the left, you notice that we had these spikes that were continuous. Just before the MDA, you notice that you have a high spike. After you give the MDA, you notice that you go low. So with those continuous spikes, we realized that we can obtain sustainable goals. So in our thinking, we had to go back to the drawing board and think what is happening between these MDA times. And that's why now from the chart on the extreme left, you notice our breaking transmission strategy. We have tried to do a modeling component for the next 5 years on how we intend to achieve elimination. And that is by integrating BCC and WASH components and the other things we learn as we go forward. Next slide, please. So based on that alignment, we have done our strategy based on the global alignment of the WHO plus XPEN, where we are trying to look into what the WHO guidelines looks into elimination and inclusion of NTDs as we target elimination. Then we have also looked into the national strategy, that's the NTD National Strategic Plan, as well as the pragmatic consideration, as well as the role of WASH in PC NTDs. So I'll touch briefly on the national policy, and which was what we anchored our pillars for the breaking transmission strategy. So next slide, please. So in the NTD strategic plan priority, we look into strengthening government ownership, advocacy, coordination, and partnership. And this allows us to ensure that we have sustainable goals and ownership from the very top of the administration coming down. Then we also have enhancing our planning of results, resource mobilization, and financial accountability, as well as scaling up intervention, treatment, and systemic capacity building, as well as ensuring that we continuously do monitoring, evaluation, research, and operation. With all this, our main goals is to ensure that we have equitable and inclusion in terms of distribution of the drugs, plus expanding our intervention as much as we can, and ensuring that we have community inclusion at an early stage, so that by the time you're doing this intervention, there is ownership within the communities that we are actually addressing. So next slide, please. So some of the Kenyan situations that have created that informed some of the challenges, and also that brought the idea behind breaking transmission, it was actually based on the challenges and the gaps that we realized as a county, as a country, and as counties. So we had a challenge in terms of inadequate mapping of all the NTDs across the country. We had limited national and county ownership, and that is also the area of sustainability challenges that are there. Then we have inadequate budgets in regards to the activities that are budgeted for, plus fragmented approach on how we approach our NTDs. Then we had inadequate number of trained personnel, so capacity building was one of those areas that we realized was a major gap in terms of the situation in the Kenya. And then we looked at opportunities that we can ride on, and opportunities were programs that are already running in the country that we could leverage our strategies on. This was like Malezi Bora, the malaria program, and a good example of malaria program is in areas where we have distributed mosquito nests. We noticed that the LF prevalence has also gone down. And other programs that we thought that we can actually leverage on is immunization campaigns plus HIV interventions as well. Next slide, please. So the main objectives of the breaking transmission strategy, it's anchored on 6 main objectives. And the first objective is to increase our MDA coverage in all endemic sub-counties. The second objective is to expand the NTD WASH intervention. The third objective is to mainstream behavior change communication. This allows a bit of sustainability plan around it. The fourth one is intensive advocacy, and this is more on high-level advocacy, coordination, partnership in NTD control and elimination programs. Then the fifth one is strengthening the monitoring and evaluation, surveillance and research, and then planning for results and resource mobilization plus financial sustainability. I'll go to each objective one by one. So next slide, please. So in our quest to ensure that we do enhance and increase our MDA coverage, one of the few things that we wanted to do is to ensure that we do community-based approach where we can go ahead and do direct observation kind of approaches for each and every individual that we target to reach, and also to try and look at unique ways where we can target nomadic and cross-border issues across MDA areas where we do the MDAs, and also try to look at opportunities in regards to research that we can do operational research during these interventions that can give us informed feedback on how to address some of these issues. Then the other thing in terms of how to ensure that we have maximum and increased coverage was to ensure that our supply chain management is well coordinated from when we requisition until when we get the drugs and how the drugs get to the communities that we intend to target. Next slide, please. So the second component was expand our NTD WASH intervention. As you notice, most of the NTDs has a WASH component. So we wanted to see how best we can link up or leverage on WASH interventions based on whatever component of WASH is ongoing and through other ministries that are highly or closely linked to WASH, and that's like the Ministry of Water and Irrigation plus the Ministry of Environment. So one of the few things that we wanted to do is also to use the NTD platform to inform them in regards to the water availability plus the water need in these communities that we can leverage our NTD platforms in. Next slide, please.
Dr. Martha, you have slightly more than 2 minutes, so please rush, rush through.
Then the third one is mainstreaming behavior change, and this is where we wanted to integrate communities in terms of sustainability plan by encouraging them on behavior change and also offering community sensitization. Next slide, please. And then the fourth one was intensifying highly advocacy, and as you note, that was the cabinet secretary when we were launching. When you're launching the breaking transmission, so there was that ownership from the high level coming down. So, and it was also included in the PC of the cabinet secretary. Next slide, please. Then the fifth one was ensuring that we have a continuous monitoring and evaluation surveillance plus research component integrated within all that we are going to do. So whatever we have started doing for the breaking transmission, we have a surveillance component that is ensuring that, and a monitoring component, and based on these results, is going to inform how effective all these strategies are going to be. Next slide, please. So the last component is the aspect of planning for results, resource mobilization, and financial sustainability. And this is a follow-up of the high-level integration of all the structures that we have in place, and that allows even counties to ensure that they can allocate some money for the NTD with a high-level advocacy. And this will finally bring into financial sustainability plan. And that's the agronomy of the structure that we currently have in Kenya. Thank you.
Thank you, Dr. Martha. I think we actually spent a few minutes in the beginning. So for the next speakers, please save us 1 or 2 minutes so that we can be able to recoup the minutes we lost in the beginning. So our next presentation will be around building partnerships. And this one will be done by Wycliffe Omondi, who is the head of preventive chemotherapy and transmission control at the national NTD program, but he will be helped by colleagues within the group. So over to you, Weekly for Monday. Please save us 1 or 2 minutes as you present. Thank you.
Thank you so much, Dr. Sultani, and hello, everyone. Next slide, please. I will take you through the Kenya Field Epidemiology and Laboratory Training Program partnership with the Division of Vector-Borne and Neglected Tropical Diseases. The Kenya FELTP program was established in 2004 and is a division within the Directorate of Public Health. When it was established, it was a collaboration between the Ministry of Health and the Centers for Disease Control and Prevention, with a mandate to increase epidemiological capacity within the healthcare staff force. Next, please. The core objectives of FELTP are about 6. The first one was to strengthen the health capacity by developing a cadre of health professionals with advanced skill in applied epidemiology and laboratory management. The next one being, the next objective being to contribute to research activities and priority in public health problems. And if you tie this to what Dr. Mwatha has alluded to in the breaking transmission strategy that is looking into monitoring and evaluation and research, this falls within the mandate of FELTP. The third objective is to strengthen the national and regional capacity to respond to public health emergencies. The fourth being to strengthen the national surveillance system within the country. The fifth objective of Kenya FELTP program is to strengthen laboratory participation in surveillance and field investigations. And the last objective of the program is to improve communication and networking of public health practitioners and researchers. Next slide, please. Now, the following captures the activities within the Kenya FELTP program. There are 4 key activities within the program. First is field epidemiology and laboratory training. Under this particular area, there are 3 courses that are being offered. One is the basic level training, and the basic level training takes 3 months. The next one is intermediate level training in epidemiology, which takes 6 months. Then the last core training provided under the field epidemiology laboratory training is the advanced level training, which is a master's course taking a duration of 2 years. The second activity that the program conducts is field epidemiology outbreak investigation. And in field outbreak investigation is important and challenging component within the public health sector. It helps to identify the source of ongoing outbreaks and inform response and control measures and develop strategy to prevent future outbreaks. So the key information here is to identify source of outbreak and also inform on mitigation measures to be undertaken by various divisions within the Ministry of Health. The third activity that the FELTP program involves in is surveillance. And surveillance informs both immediate and long-term strategies for combating infectious diseases, as it provides various divisions within the ministry with information to guide on informations. So the FELTP program provides various divisions with support on data collection on various health activities. The last activity that the FELTP program conducts is improving public health management for action, which is abbreviated IMPACT. And this is a very recent activity that was launched in 2017 to help public health officers with the management skills in public health profession. Next slide, please. I want to take you through some of the achievements of the Kenya FELTP program. Since inception in the year 2004, 189 FELTP graduate fellows have been awarded with degrees in the advanced epidemiology course. And as I stated, the impact which was launched in the year 2017, so far there are 8 graduates who have passed through the program. In outbreak investigation, the program has conducted over 100 investigations and is having presence in all the 47 counties in the country. Next slide, please. Now, the core of being here is to enumerate some of the activities that the FELTP program has had with the Neglected Tropical Diseases program. And one of the key activities that have been achieved between the two divisions in the ministry is that 3 FELTP fellows have been attached to the NTD program to provide technical support to the NTD program. One of the fellows who have just spoken, Dr. Mwatha, was one of the graduates that have been attached at the program. Number 2, one of the program fellows currently is on final year, is from the division of vector-borne and neglected tropical diseases. And this is looking at the long term of sustainability towards epidemiological activities within the division of vector-borne and neglected tropical diseases. Number 3, the FELTP program has conducted a number of research activities jointly with the NTD program in the following specific disease areas: trachoma, lymphatic filariasis, and soil-transmitted helminths, which Dr. Mariga is going to enumerate on some of the results that the program conducted with the NTD program. The last collaboration between the FELTP program and the NTD has been seen in outbreak investigation, and this is key in 2 areas. We have 2 diseases that we've conducted joint outbreak investigation, that for leishmaniasis and dengue and chikungunya. Next slide, please. These are our partners who support the FELTP program. Division of Vector-Borne and Neglected Tropical Diseases, CDC. Children Without Worms have sponsored the 1 FELTP fellow, Kenya Red Cross, County Departments of Health, AFENET, Moi University, Kenyatta University, and AFENET. Thank you so much. Over to you.
Thank you, Wycliffe. Thank you very much. Now, this is a very interesting way of doing a conference where we are doing it online. And we were supposed to have Dr. Mariga coming on next, but the speaker after Dr. Mariga requests that he goes first because he's having a little bit of challenges with power. So we'd like to see if he can be able to deliver his lecture before his battery runs out. And so if you allow me, I will call upon Dr. Ben Masira from AFENET, so that he can take us through some of the regional approaches that AFENET is looking at being able to engage. So over to you, Dr. Ben.
Yeah, thank you so much, Dr. Sultani, and thanks everyone for attending this conference. So I will be presenting on the AFENET and our vision for building NTD capacities among field epidemiology and lab training programs across the African region. Thank you so much. Next slide. This is just the outline of the presentation. Next slide. So AFENET basically is African Field Epidemiology Network, and we are a non-profit networking and service alliance of field epidemiology and lab training programs in Africa. We have been a primary implementing partner to develop and sustain FETPs in sub-Saharan Africa for over 10 years now. And in this collaboration, we are working with the Ministries of Health, Ministries of Agriculture, National Public Health Institutes, and other partners to deliver on our goals. And our vision is the healthier Africa. Next slide. So this is basically our footprint, in sub-Saharan Africa. In blue and yellow are countries where we have field epidemiology and lab training programs in sub-Saharan Africa. And green is countries where we just have projects, but without FETPs. On the right is AFENET regions. AFENET is now divided into 7 regions in sub-Saharan Africa, as you can see in that map. Thank you. Next slide. So these are basically our 7 strategic priorities as AFENET, and we are going to be looking at these later on in the subsequent slides. Next slide. So under the field epidemiology capacity development strategic objective, we have supported training of over 2,000 advanced FETP graduates from our 16 programs across the region. And these are indicated on the map, on that map. Next slide. Then under the intermediate FETP program, these are 9 countries where we are having these programs, and we have supported training of over 250 graduates as indicated on that map. Next slide. And over 4,900 FETP graduates from our 23 frontline FETPs have actually graduated by 2020. Next slide. So our next strategic objective and priority is public health lab capacity development. And under this, we have several collaborations with the different partners. We are collaborating with the US CDC to support lab capacity development for HIV viral load scale up and recency testing, Angola, Dominican Republic, and the Caribbean region. And the key activities under this strategic priority are recruitment and placement of different lab advisors, training and mentorships of lab staff, procurement and supplies, developing plans and SOPs, and then strengthening lab management towards accreditation trainings. Next slide. Public health disease surveillance and effective response is the third strategic objective and priority. And in 2018, we established what we call AFENET Core Disease Detectives, ACOD, which is a civil, voluntary, professional, and service of culturally competent field epidemiologists. It's built on a One Health approach. And the membership under this ACOD are the FETP graduates and residents. And these ACOD are supporting ministries of health in sub-Saharan Africa to be able to respond to public health disease outbreaks and other emergencies. Next slide. So we have supported a number of outbreaks and other public health emergencies. Outbreaks of Ebola in Uganda, the 10th and 11th EVD outbreak in DRC, the cholera in Zimbabwe, Harare, Zimbabwe, COVID-19 and other public health emergencies across our continent. Next slide. Under the same strategic priority, we are partnering with different organizations and agencies, including the MasterCard, Africa CDC, GoOne, Resolve to Save Lives, World Health Organization, and the US CDC to respond to disease emergencies across the continent. Next slide. The fourth strategic priority is public health program management and research, research development. Under this, we are in collaboration with the CWW project under the Task Force for Global Health to conduct surveys on STH, the epidemiology of STH, including Kenya and other countries. Next slide. Then other NTD activities, including evaluations of the feasibility of stopping onchocerciasis mass drug administration or ivermectin in Tanzania. We are also including Malawi and Ghana starting this September. Then we are also collaborating with the Ministries of Health to implement HIV projects related to HIV prevention and control. Oxford University in strengthening lab diagnostic capacities for Epstein-Barr and other NTDs. We are also running several fellowships related to antimicrobial resistance in Tanzania. Next slide. So we are all, the fifth priority is networking and collaboration for public health advancement. We are actually networking with several networks of field epidemiology training programs and universities across the world to be able to make our continent and the world safer. Next slide. Next slide. So the seven priorities actually are promoting the One Health approach across our network. Under this, we are actually conducting frontline trainings in countries like Burkina Faso, Ivory Coast, DRC, Guinea. We established One Health platforms in Uganda, Tanzania, and other countries. We have what we call field epidemiology training programs, the VET sector. These have been done in Uganda and Liberia. We are also supporting public health institutes in advancing the One Health approach in countries like Nigeria. And then we also support development of One Health strategic plans. Next. Then what is AFENET's role in NTD prevention and control? So we have been collaborating with several partners to support NTD control and elimination in sub-Saharan Africa over the years. These partners include the US CDC, USAID, WHO, the Task Force for Global Health, and under the project known as the Community Without Worms. Then other projects include NTD Zero surveys. We are conducting projects on validation of onchocerciasis, OV16 testing, validation of lymphatic filariasis tests, assessments of threshold for stopping onchocerciasis, ivermectin treatment, and then STH community surveys. Next.
Okay, Dr. Ben, you have slightly less than 2 minutes. Please work
Yeah, thank you, Sultani. I'm actually winding up. So the role of the FETP workforce in NTD prevention and control. The FETP is involved in strengthening public health workforce, improving health surveillance and response to NTDs, enhancing research, epidemiology, and policy capacity in sub-Saharan Africa, under which we are actually supporting improving the culture for evidence-based decision-making, and also providing technical assistance across our network. Timely and effective response is also one of the responsibilities of the FETPs. And then lastly, is their contribution towards the reduction in morbidity and mortalities associated with the NTDs. So thank you so much, everyone, for listening to me.
Thank you very much, Dr. Ben. That was a very good presentation. So as we had said initially, I think now it's coming together. You can be able to see that there is this element of coordination and then integration. And we are just looking at also the possibility of being able to benchmark, at a regional scale. Now, Our previous speaker was supposed to take us through one of the products of collaboration. And you remember we actually used the case of collaboration with the FELTP program. And through this, we have been able to collaborate, use the infrastructure within FELTP to be able to conduct one of the very first community-based STH and schistosomiasis surveillance activities. From the breaking transmission strategy, you'll realize that our goal is very clear. We want to eliminate. And when we talk of elimination of, say, schistosomiasis, for example, we have to zero in on that very village that has schistosomiasis so that we can implement comprehensive activities to ensure that it is eliminated. And from the previous speaker who told us about regional integration, we want to remain with the challenge of being able to see how do we deal with an area like the Lake region between Kenya, Uganda, and Tanzania with a freshwater lake as big as Lake Victoria. How can we be able to do it? So just as we continue thinking about it in our minds, I want to bring in Dr. Denver Mariga so that he can tell us about leading community-based STH and schistosomiasis surveillance activities. Over to you, Dr. Mariga.
Thank you so much, Dr. Sultani. I'm Dr. Denver Mariga. I'll be presenting on leading on community-based STH and schistosomiasis surveillance activities in 2 counties that we were able to do in Kenya. Next slide. Next slide. Basically, when we are doing a survey, we always have to have at least some objectives, and our objectives in this case were to enrich outcomes through stakeholder engagement, reducing the likelihood of reinfection, which contributes to elimination, and encourage long-term sustainability and community ownership, and integration of NTD programs into other programs for collaborative activities and risk reduction. I'll just talk about this as we go on. While doing this, how are we able to build a resilient program? We need to know the entities that afflict the community in the locality, who are the vulnerable populations, and what are the consequences. And how does building a resilient program impact the community in this level? Next. Just go back to the previous slide if you don't mind, before we go to the practical experience. When we are conducting fieldwork, we always look at the community of where we are going to. All in all is that when you're looking at the community, there are basic ways that you need to meet for you to be able to go into the community and be able to meet your objectives. In Kenya, we are blessed. We have 2 different levels of government whereby you're supposed to at least go through both of them. And before you get to the community, there are requirements that you're supposed to meet before you go in. In Kenya, having the county and the national government, we have 2 command structures. And you're looking at the methodology that you used for you to be able to conduct the study or the survey that you used. Using the 2 methods, you'll definitely be able to get your objectives if you're going to look at the implementation unit being at the lower level. But the interest comes in who are you going to meet before getting a buy-in into the community. We have the national system, which has more or less a county commander, and then below them there are chiefs who are able to get you into the community, and the county system where you have the devolution system. You need to go through the county, then sub-county, and then the wards, and then before you get to the villages. So these are the things that you need to put into perspective before you're able to do that. And what is the population that you're looking at? Who are the vulnerable that you are looking at so that you're going to get your data? Are they people who are either the poor in the community or upper class? As we've seen in the studies that we've done, our methodology was able to look at both sides. We got sample sizes from both those who are able and those who are not able, and looking at the consequences of the test that you're going to do. STH is a lab-based survey program that you're going to do. What happens when you get those ones who have STH within them? Are you going to offer treatment or are you going to then refer to them? So there are so many resources that you need in this case. You might need resources either while going to the field or after when you're linking them to care, and ensuring that all this treatment gets to the people who are supposed to get it. And then when you are building a program within a resilient program within the community, how is this program going to be sustainable? As we've seen in Kenya, we are blessed in a way that the community health volunteers are able to be administered with the drugs, and during their visits to households, they're able to give families periodically 3-month intervals so that we can be able to get rid of STH. But you realize that being a program, you need to incorporate and integrate with others. You have ANC, where we have our community health volunteers who visit homes. So during that time when they're going to give ANC education and all that to the afflicted families, you also should empower them that they're able to also mention about NTDs. There are some NTDs that are still neglected, like Tungasi. These are the ones that mostly affect the poor people in the community. And as you go into the community, you find that, yes, we went in to do an STH survey, but you find that there are other things that you also need to take care of. And this one necessitates the program to be able to change the tact when going to the field next time. And what happens is that during this time or subsequent ones, you need to educate the people that you're going to use. If you're going to use community health volunteers for household visits, you also need to get a background of the community of where you are going to, so that you can be able to look at the impact you're going to give them. We might look at STH, give and albendazole, and you're done. But what about the patient who you've left? After how long are they going to be able to get the medications after that? So that you can also be able to reduce on the infection that occurs within the community. Next slide, please. As you can see here, we have a practical experience at different levels. My colleague, Dr. Mwatha, in the first slide, it was during a community health volunteer sensitization. And then we also had household visits with some of our colleagues when we are going to each household, getting stool samples, and also educating them on STH. Luckily, we've been involved, I've led 2 studies for STH in the country, and we were able to learn a lot during this time. And after that, also involving the stakeholders who are mostly the lab people who are mostly not considered at the forefront. During the planning phases of the budget and all that, we tend to look at their job as if it's more or less expendable, but it's long-term. And continuity of that, of the people that you use in your survey, needs to happen in a way that the people doing this are people from the local, so that even if somebody is sent in later on in the lab for any other thing, they can also be able to do a test for STH and be able to give the clinician direction on how to offer treatment in this. Next slide. I would like to thank our donors who are able, we work with the CWW, Sci-Fi, and the NTD program and the MOH. And during that time, we were able to achieve our objectives. And it's in this regard that we hope that in the next surveys that are going to happen, we'll have more footprint on the ground and be able to eliminate STH. Over to you, Dr. Sultani, the moderator.
Thank you very much, Dr. Mariga. I think you are reporting straight from the community, and we could hear quite a bit of activity within the background. Now, we are now at the point where we want to have some discussions around the presentations that have been made, and we are actually encouraging that if you have any issue that you'd like to be discussed or any question, you actually put it in the chat. Cara will be looking at them and bringing them up so that they can be addressed. So feel free to put your concern into the chat, and then it will be brought up. So at this point, I'd like to hand over to Cara Tupps, who's going to take us through some kind of Q&A section or some kind of discussion around what has been presented and anything else of interest to the participants. Over to you, Cara.
Thanks, Dr. Sultani. Hi, everyone. We have a few questions already, but feel free to add to the chat box. We have a few minutes to answer some. So the first one is for Dr. Mwatha from Emmanuel Amuka. How did you manage individual disease MDA approaches in the context of integration?
Sorry. So maybe to address the first question, how we manage individual disease MDA approaches in the context of integration. One of the few things that we have done, considering the 4 PCs, is looking at what each MDA does and at what season. And one of the few things that we looked at, a good example is LF, where in LF we use albendazole, DEC, and now we integrated with the third disease, ivermectin. And we realized in such communities, we still were doing approaches for school-based deworming or for albendazole. So one way we looked at it is this individual integration, how best we can write on already existing platforms to actually integrate a common drug. And that's like LF will integrate albendazole, where you give albendazole, and that one will cater for the STH within that community that we are trying to target. So we looked at each individual disease and looked at ways of integrating those individual MDA platforms that we can write on. So that's how we looked at individual MDAs and then looked at opportunities for integration as well.
Okay, maybe Cara, before you take us to the next question, I could like to just weigh in a little bit. I think the whole issue around integration is really based on co-endemicity. So that is the first, you know, attribute that dictates integration. So in an area where we have any of the 4 PC NTDs that are endemic in Kenya, in an area where we have them co-endemic, then we look at how possible it is to integrate distribution of MDA for all the ones that are co-endemic. For example, we are already doing it for STH and schistosomiasis in areas where it is co-endemic. We are already doing it in the coast where STH is co-endemic with lymphatic filariasis. Now we are looking at best ways in which we can be able to you know, integrate implementation. For example, in the coast where we have, in addition to LF and STH, we also have schistosomiasis. So we are looking at the possibility of being able to conduct 2 MDAs, but organized in such a way that we deliver the first MDA, and then maybe after about a month or 2, we are able to now deliver the second, so that we don't also overburden the communities with MDA. We have a few areas where we have co-endemicity of schistosomiasis, sorry, STH and trachoma. And last year we carried out a small survey just to see if there's going to be any adverse reactions if we co-administer azithromycin and albendazole. And luckily we were not able to observe any causal relationship between co-administration and adverse events. So it is something that we are now thinking of being able to come up with the new approaches that can allow us to integrate as much as possible. So back to you, Cara, so that we can continue with the Q&A.
Sure. So the next question that we have is from Duncan O'Sholl, and it is, what is the strategy to improve domestic resource mobilization? I don't know if Dr. Sultani, you want to comment on that, or maybe Dr. Mwatha?
Okay, I think because we have Weekly for Monday on the call, he can go first, and then maybe I can fill in a little bit more. Wycliffe, do you have anything to say?
I didn't get the question, Dr. Sultani.
So Duncan Ochol is asking, what are the plans around sustainability, especially with the local resource mobilization? What is the plan to be able to mainstream sustainability and stop this overdependence on external funding?
Thank you so much. On sustainability for our implementation activities, one, we are looking at partnering with the county governments that are charged with the responsibility of providing health to the community members, so that they can, areas where we've identified endemic NTDs, they can allocate resources towards the identified NTD. That is one way of moving away from donor funding. Number two, we are also trying to see if we can partner together with some of the in-country entrepreneur companies to see if they can also provide some mechanism towards intervention for the NTDs in the country. Over to you.
Thank you very much. Dr. Martha, anything to add?
Yes, I'm here. So the other thing that definitely we have also tried to do is to involve the high-level stakeholders approach, where we ensure that even our top leaders are involved in our planning processes. And even when you look at the algorithm that we're currently using for the BTS, the Breaking Transmission Strategy, we have an NTD steering committee that is actually nominated by the cabinet secretary herself. So with that, it actually pushes even the local leaders to actually factor in aspects of NTD, and that all allows the ownership and even in resource allocation around it locally. Thank you.
Okay, so Cara, maybe before I give it back to you, I think I just wanted to, that has been well covered, but I just wanted to add another aspect. With the implementation of the BTS, we are expecting, and you could see the graph that Dr. Mwatha presented, we are expecting to see very significant reduction in prevalence of the NTDs. And so we are also expecting that the areas that will need intervention within another 5-6 years are going to be drastically reduced. And so the whole burden that will be required in terms of resourcing will be significantly reduced. And that will make it much easier for us to be able to even source from within government, to be able to source whatever is required to sustain some of these interventions that we are talking about. So of course, we will depend a lot on external funding for now, but then as we continue implementing the BTS, it is envisioned within the strategy that the requirement is going to reduce quite a bit. And then the other thing that is very important for us to be able to look at is that we have allocated quite a lot of resources to advocacy. And I think Dr. Mwatha has alluded to this, and also weekly. So we are targeting not just the community, but also the policymakers. We are targeting the implementers, even at implementation level, the health workers and so on. We don't want to wait for MDS. We want people to be able to pick out some of these diseases, even in between MDS, so that we can have a system where the public health structures are able to pick some of these diseases. And we believe that with the combination of all these factors, then we should be able to have a very easily sustainable program within another 5 to 6 years. Over to you, Cara.
Thank you all for that. The next question is from Martha Saboya. She wants to know, this question is for Ben, about the One Health platform within AFENET and what the components are. Ben, are you still with us?
Yes, thank you, Cara. Yes, the One Health platform actually, as indicated in the presentation, we are supporting some ministries, like as I mentioned, Tanzania, Uganda, to actually augment the One Health activities within the country, because as we are aware, human medical public health problems, they are not necessarily human. I mean, there is environment around them and other aspects. So we are very much aware of that, and that's why we are actually trying as much as possible to make sure that in every public health intervention, there is a One Health approach across, cutting across, those responses. So we are working towards strengthening that aspect through field epidemiology training programs as well. We ensure that when these trainees are being recruited, we look at that aspect of One Health. You must recruit from vet, you must recruit from human sector, environment, and other sectors. So we are using both, direct support to ministries of health, and then through FETP trainings. Over to you, Cara. Thank you.
Thanks, Ben. We have another question for you from Joseph Anyango. We share more on long-term sustainability structures and community ownership strategies.
I beg your pardon, Cara?
Can you elaborate on the long-term sustainability structures and community ownership strategies?
Yeah, of course, for FETPs, again, the other presenters I've mentioned, the sustainability of FETPs actually lies with the ministries of health and other partners, other government partners. So although we are doing this as AFENET to support FETPs, we are very much aware that for them to be sustained and rely less and less on donor funding, the governments must actually take up ownership of these FETPs and then also increase their allocations for the FETP to support FETP trainings. Of course, we can't forget the other aspects, like, once these graduates actually graduate, the countries are also struggling with the, establishing a career path for these graduates across our region we are supporting. So if this career path is well defined, we also think that the sustainability of these FETPs actually, they will be, much more sustainable. Over to you, Cara.
Thanks. So we have another for Dr. Mwatha. What is Malezi Bora? Dr. Mwatha, are you still with us? Oh, he may have dropped off.
I will just try and check for you, Cara.
Okay, thanks.
Okay, so I think if Dr. Mwatha has dropped off, maybe Wycliffe, you can chime in and take that up.
I think we might have lost Wycliffe as well, actually.
Okay, sorry, these are the challenges. Yeah, these are the few challenges of having an online delivery mechanism for these kind of activities. But so maybe I'll just come in and address that. So in Kenya, we have the Malezi Bora program. In Swahili, Malezi Bora means good, taking care of children, good care of the young children. So we usually have a duration of about a week. We have a Malezi Bora week twice a year, 6 months apart, where there is a combination of interventions that are provided for both mother and child to just boost the health outcomes, around the children. So it is a raft of interventions, vitamin A supplementation. There's a lot of advocacy and health education to the mothers, and then it also involves deworming. So albendazole is provided, mebendazole for deworming, just as part of the nutrition package. And of course, although this is done to improve the nutritional status, we know that it also impacts very much on the STH and other entities that are dependent on albendazole. Now, one thing that is important for us to note is that for our country program, before we started the BTS, we were only able to practically address the need within the school-age children. Although now we have been able to expand it and we are going out for everybody who is eligible in the community, we were not able to reach the under 5s. So Malezi Bora actually was able to come in and cover a big chunk of these children under 5 years, as the school-based deworming activity was taking care of the school-age children. But now we have come up with this comprehensive BTS strategy, which looks at the under 5s, the school-age children, and the adults within endemic areas. So I think, I hope that has been useful. Thank you.
Great. So we have a couple more minutes. We can wrap up these questions, I think. And I'm not sure if Dr. Moatha or Wycliffe are able to join yet, but they're trying. So maybe Dr. Sultani, you can comment on how you've been able to integrate WASH data into the BTS.
Yeah, we are here with Dr. Mariga, so I'm sure we can be able to handle on behalf of Wycliffe and Dr. Moatha before they rejoin. So Dr. Mariga, you'd like to go first, or you'd like me to just take it?
Just go ahead, Dr. Sultani.
Okay. All right. Thank you, Dr. Mariga. So I think as it is clearly illustrated in the BTS strategy, we have a very innovative way of mainstreaming WASH interventions. Actually, we are talking about expanding WASH interventions so that we can leverage the WASH component in our effort towards elimination. Now, we are not looking at going in to provide the water or to construct the toilets as an NTD program. What we are investing in is to build a collaborative, a working collaboration with the WASH sector. And I think Dr. Moatha had alluded to that. So we are now we have established a WASH technical working group, which has, representation from across board within the ministry and even beyond. We have a representation from the Ministry of Water, from the Ministry of Environment. And what we are doing is we are providing information which will inform, or which is informing, the implementation of WASH interventions within NTD endemic areas. So the WASH partners who are on board within this technical working group are coming in, and we are able to direct them and tell them, we have a lot of trachoma in this area, but then we don't have water. So they actually now look at their own WASH map, and then they say, okay, yeah, we have a lot of interventions in this area, but we don't have any interventions in this trachoma endemic area. Now, we are actually now planning with the help of partners, and Michaela, I'm happy you're the one who has asked this question, because we are in discussion with site savers to be able to now roll it down so that we can bring in the county governments, which are like regional governments, to also take up this, and then we can be able to even be more effective in terms of reaching the coverage that we want to be able to reach. So maybe in a nutshell, we are looking at a coverage of about 40% for water. When we look at the households and the schools and facilities, we were looking at a high of 40%, and in some areas actually very low coverage. So on average, it is much lower. But we want to be able to push it through this collaboration so that at the end of the day, we have at least 85% of the households and the institutions having access to safe water, which we believe is really going to drive the breaking transmission goal. Thank you.
Great. Maybe we'll just take one more. This one's for Ben. What's the gender distribution of FETPs, and are there specific targets to train female epidemiologists?
Yeah, thank you so much, Cara, for that question. Yeah, FETP, of course, at recruitment, there's no segregation. We are recruiting both males and females. However, at the moment, the gender distribution tends to favor the males. There is a slightly higher proportion of males as in compared to the females. So the reasons for that are not very clear. Maybe the females are not, much interested in FETPs, but I think that's the situation. There's a slightly, I think we are talking about 60% males and 40% females. So I think that's a gender distribution. I hope I have answered.
Thanks. Okay, just a reminder that we will be recording all of these unanswered questions in the main chat box of the session, and then we'll be sure to come around to those later. So keep an eye on that. And now we are going to go into our breakout sessions. So everybody is going to be automatically allocated to a group, and then we'll discuss together in these groups what are the opportunities and challenges to integrating NTDs into national health systems. And I'll put that prompt in the chat box.
Sorry, Cara, just before we break out, I know that we were supposed to have chairs within the groups who will direct the discussion. And some of them are Wycliffe and Dr. Mwatha, who have dropped off. So probably we can try to quickly make arrangements to see if the groups can be able to appoint a chair, and then who can be able to now moderate the discussions, so that we don't have this kind of, when the groups are formed, we do not have a situation where there is no chair and people don't know what to do. I don't know what your take is around that.
Let's ask Debbie, can we switch to 5 groups? Because there's myself, Dr. Ben, Dr. Sultani, Mariga, and Girja were prepared to lead.
Okay, let me just see if I can do that. So I've deleted Wycliffe's group. Girija, you are down in Stephen Mwatha's group, if you're happy to lead that one. So we should have a chair in every single group. If I could just quickly just run through a few housekeeping notes for the breakout rooms. So you will automatically be moved into the breakout groups. I will just be reshuffling a few of those people from that 6 breakout. So just take a couple of extra seconds. So don't worry if it takes a few seconds. Once you're in the breakout, please turn on your video using the button in the left-hand corner. And you may also unmute yourself when you wish to speak and participate, and then please kindly mute yourself again once you've spoken, just to avoid the background noise. We're going to open the group work for about 15 minutes, and I'll send a warning 5 minutes before, and at 60 seconds before, you'll get another warning which will automatically send you back. Don't worry if you come back into the room, we'll pop you back into your breakout room. If you could just make a note of which group you're in, the facilitator's name, that would be fantastic, and then we can pop you back in the same group. Okay, I will press the button and open the breakout room, so see you shortly afterwards. Thank you.
Thank you very much, Debbie. I think for our group, we got cut off as we were winding up, but we will probably go group by group, so that if the rapporteurs or the chairs from the different groups can be able to take us through what are some of the opportunities that they came up with and what are some of the challenges. I think Girija and Cara will be at hand to capture, so that we can see out of the session what are the issues that came up. So, Cara, would you like to take this up? Because I can see on the program, actually, it is yours. Yeah, so you can take it over.
Thanks. So I'll start with an apology. I'm not sure what happened. I think when we switched facilitators, maybe it overwhelmed the system a bit, but I hope everybody was able to have some discussion. And from our side, we talked a lot about the siloing of programs, both within NTDs, but also across the health system, from NTDs to the wider the system as a whole, as a potential challenge to integration. And especially cutting into that is the separate donors and their competing priorities, and the separate budgets that exist within each NTD, but also, for malaria and so that was a challenge. And then someone shared, we got caught off there at the end, but was sharing success in Malawi, where they were able to negotiate with the government to have an NTD coordinator to help coordinate across the NTDs, and to have national NTD coordination. So I think that's an important thing to highlight. And then we had someone comment on the lack of standard treatment and prevention strategies for all NTDs, and especially in data collection, which is a potential challenge. So if maybe Girja, if your group you'd like to present next.
Yeah, absolutely. I'm going to see if Dr. Mwatha's internet connection is stable, and if it is, then I'd invite him to share, because he did lead our session.
All right, thank you so much, Girisha. So I'll give the 4 main points that we took back home. So one was data integration. There's need for data integration of the NTD data into the normal data reporting system. Then there's an aspect of human resource, seeing how NTD can be linked with the national health framework so that you don't have aspects where when you're doing activities, the healthcare workers are already involved in other activities because they may be the same healthcare workers that we are looking into. Then there was an aspect on capacity building as well, how best we can integrate, strengthen the capacity building around NTD so that it's easy for inclusion within the normal health system. And then the last one was on infrastructure and trying to ride on other existing platforms like the vitamin A for under 5s and seeing how best we can ride on that in albendazole as well. So those were some of the take-home messages that we got from our group. Thank you.
Great, thanks. And Dr. Sultani, would you like to share?
Yes, absolutely. We had a very good discussion, and I think I'll request, we had a very good rapporteur in Victoria Fapohunda, who can come up and probably, I don't know if she's able to speak on this platform, Victoria?
Yeah, I can.
Okay,
Yes.
go ahead.
Thank you.
Okay, Victoria, just sorry, just to let you know that if you wanted to share your video, I've just changed the settings so you could have another go at sharing it now.
Okay, if I should share my video, it will affect my internet.
Oh, no problem. Okay.
Just go ahead,
Thank you.
please.
Okay, so can I continue?
Yes,
Yes,
please.
please.
Hello?
Yes, please, Victoria, just go ahead.
Okay, from what we discussed in our group, I'll start with the challenges. One of the challenges we talked about was compliance with donor requirements based on the country's needs, and sometimes some of the donors' resources are used for other programs. And you know, the donors will insist on you using the resources for what those resources are meant for. But when you discover that you have other programs that need some of the resources, you have to use them together. That can be a challenge. Also, incentives are lower in NTD's program compared to other public health programs, because most of the NTD's programs are run by volunteers who see the incentives coming from NTD's program as lower compared to other activities, other public health activities, and decide to skew to that end. Then I'll move to opportunities. One of the opportunities we talked about was stigmatization of most of the NTDs will no longer be an issue, but rather an opportunity for sensitization to the larger group. Then integration of IEC materials into other public health IECs by creating awareness in the community, thereby sensitizing everyone on the importance of having an integrated program rather than having a standalone public health program. This will create more awareness to the communities on NTDs as a whole, rather than just them knowing, of other public health programs such as family planning alone. Then you talk about soil transmitted illness alone. But now, when you have to integrate public family planning, you have to integrate female genital schistosomiasis into family planning. Then people will have more knowledge on most of these entities. Then also, we're looking at integration, also helping to reduce public health budget by leveraging on all resources available. You know, when we have programs pooled, when we have resources pooled together, it will definitely help to achieve the targeted goal rather than one struggling in NTD or struggling in other public health activities when the resources are put together. Another opportunity we recorded in our group was integration also helps to increase efficiency by training personnel in different entities, especially when there is low manpower. You know, in some countries they may have issues of low manpower, like them doing shifts. And if you train a particular person now, you hear the person has been transferred. But when you train people in different NTD programs or on different entities, they then have knowledge on what to do when the time comes. That's just about it for our group. Thank you.
Thank you. So I think Cassandra was taking notes for one group. Would you like to share?
Yeah, one of the big takeaways was knowing the makeup within the country. So the implementing partners, key program people and others, and making sure that they work with the ministries of health and that they make sure that they get together and identify where all of the different programs are doing their different mass drug administrations and other projects, so that they can have a clear understanding of the entire country's makeup for NTDs and what's necessary to have a joint effort. But they said, also shared that some of the countries have very small issue with trachoma and big issues with STH. So it's kind of hard. How do you find the proper partners to pull together with the Ministry of Health to incorporate them into one big program for NTD prevention and elimination?
Thanks. Okay, so we're a bit over time. I know there was one more group, but I think Dr. Mariga has dropped off again. I don't know if anyone on the call was in the group wants to share just like 10-second overview of the key highlights.
Okay, thank you.
Oh, you're here. Good.
Our group, we mostly concentrated on the opportunities and the challenges. And one of the challenges of integration was the fact that NTD activities are done during a specific time of the year. And it only comes out that it has activities during that time. The interest is only during a short time, and then over a long period, most people went off of the interest. So you find that even the staff during the program are unaware of the changes that have come in or the development in the knowledge within the NTD program. We also found out that there is a problem with bringing out indicators which can be enhanced and provided in international health, because they are found to be only concentrated during a specific time. And some of the members mentioned about the M&D platform for the NTD. On the opportunities, we looked at partners coming in and looking at the impoverished people who are mostly affected by the NTDs. And this one will require a lot of investment from the global and the health programs within the country, and integrating the local government to be able to take up all these objectives. Over.
Thanks so much. And I think that's all the time we have. Just a reminder that we will share the slides from the presentations. And thank you all so much for your participation.
Thank you very much. Thank you to all of our host speakers and attendees for your contributions. I'm now going to close the meeting and hope you enjoy the next workshop tomorrow morning. Thank you. Bye.
Thank you.